Welcome, everyone. My name is Stephen Collins. I'm the CEO of Matter. Today, we have one of our signature programs, Tales from the Trenches, where we talk with seasoned entrepreneurs about their journey. How did they get started? What are they trying to accomplish? What have they learned along the way? We produce Tales from the Trenches with VillageMD, which is a Chicago-based company innovating in value-based care. Our guest today is Dr. Anand Iyer, Chief Strategy Officer of Welldoc. Anand joined Welldoc in 2008 when the company was really in its infancy. And over the last 12 years, he's helped transform the company into a global leader in digital health and chronic disease management. He has type 2 diabetes himself, so he approaches his work with a deeply personal understanding of the challenges facing people living with diabetes. Welldoc's flagship product is called BlueStar. It's the first FDA-cleared mobile prescription therapy for adults with type 2 diabetes. I met Anand when we were on a panel together at last year's health conference about a year ago on digital therapeutics, and very much enjoyed his perspective. I know that you all will as well. Our moderator today will be Paul Martino. He is co-founder and chief growth officer at VillageMD. Prior to starting VillageMD, he was a senior vice president, held a number of leadership roles with Anthem and WellPoint, and has been in the healthcare industry for 30 years. If you have questions for Anand, use the chat function and Paul will incorporate those into the program. And for those of you who signed up for the post-event networking, you'll get an email from Kay Nietzkaj in a few minutes that will include a separate link to click on at the conclusion of the main program. It's going to come from kay@matter.health. You need to exit this Zoom and click on a new link at the conclusion of the main program. And with that, I will turn it over to Paul to lead this conversation.
Stephen, thank you very much. Really appreciate the introduction. Anand, good afternoon, I guess it is, right? How are you?
I'm doing well, Paul. How are you?
I'm good, thanks. Where do you find yourself today?
Potomac, Maryland at home, not too far away from our head office in Columbia, Maryland. And yourself?
I'm sitting in my spare bedroom here in Chicago. The day's teasing us a little bit for those of us that are in Chicago. It started out really overcast and rainy, and the sun's trying to peek through. You know how this goes just before winter, right?
We're exactly the opposite. I hate to say it today, but 77 degrees and sunny. So we'll take it as long as it is.
Yeah, that's beautiful. Yeah. So a couple things I'd like to try to do today. First, I'd like to explore your journey a little bit personally, and then I'd like to sort of correlate that to your work, Welldoc, and then the work at Welldoc. So let's start with you. Maybe you can share a little bit about you, your educational background, and ultimately, how did you come to Welldoc?
Yeah, so first of all, I sincerely appreciate you taking the time to do this, and thanks to Stephen as well. Thanks to Matter and to VillageMD. This is a fun thing to do, and it's always good to share experiences. I think we're all trying to raise the tide on this opportunity. But by way of background, I'm a wireless telecom guy, believe it or not. All background in electrical engineering, PhD and an MBA from Carnegie Mellon University, and when I left Carnegie Mellon back in '93, I joined a firm out of Boston called PRTM Management Consulting. And one of the premier management consulting firms, two technology-based companies, right at the dawn of what we called 2G cellular here in the United States. And as a telecom guy, I was given some opportunities to grow the firm quickly and grow the capabilities for us to do advanced technology strategy consulting. So did a number of things around the globe, started numerous wireless operators here, first started supporting the launch of Nextel, and then companies like Vodafone and companies like NTT Docomo in Japan, etc. And as we went through that journey, we started to quickly grow from just laying the pipe, the foundation, if you would, for this disruptive technology, and started to say, now that you have the pipes in place, what services can you do on top of that, right? And that services layer quickly grew to things like automotive telematics with Ford and Volvo and others. It grew to RFID policy, a radio frequency identification policy for the Department of Defense, smart highways in India. And it was in that journey around the 2002 timeframe that I developed, as Stephen mentioned, type 2 diabetes myself. So I affectionately joke that the two things that define me, one is good, which is wireless in my blood. One is not good, which is too much sugar in my blood, but somehow Welldoc has managed to fuse the two together. And we asked a simple question saying, is it possible that we could, whilst we've done wireless in every other industry, retail, manufacturing, supply chain, automotive, et cetera, banking, can we not do it in healthcare? So we started working with the usual suspects, the Siemens, Hillroms, GE Medicals, starting to do things like automated tracing of equipment in a hospital, making sure that patient A in hospital bed A got medication A, so that you're reducing, medication errors in hospitals, which is still a concern. It's not a light point to take. And it was in that journey in the 2005, 6, 7 timeframe that proverbial napkin discussions at conferences, and met an endocrinologist who was commiserating the state of diabetes management. And there had to be a way to leverage mobile technology. There had to be a way to leverage mobile technology in the way forward. And in many ways, that was it. I consulted with them for a year and a half, and then ended up joining the company, as you said, in 2008. And so for me,
yeah, tell us about that. I want, like, what, 2005, the company started. You and I had a prior conversation, and we were joking around about these things, right? The smartphones and what it was like to be in the mobile business back in 2005, 2008. Share a little bit of that.
Yeah, no, it's funny. I always say it isn't the phone that you just showed us, right? It was the Nokia 6100 where you had to press the 3 key 4 times to get the letter F, right? It was that phone.
That's right.
And when you think about it, Jobs hadn't come out with the iPhone yet, right? There was no iPhone. That came in 2007, late 07. Right? And the concept of an app wasn't there. So can you imagine going to stakeholders, saying, I think I have something, let's call it an app, that can actually help a patient and a provider jointly, if you would, manage, in this case, type 2 diabetes. At the time, today, it's a much grown portfolio of disease conditions and products. And people look at you with kind of deer in the headlights. What's an app? Can you imagine the reaction from the FDA first time we approached it?
Yeah, of course, right.
And even the wireless operators at the time, because there was no app store, right? And so to get an app, you had to actually go to the wireless operator and get it certified on their network, network by network and device by device. And think of going into an AT&T or Verizon store in 2007 and just remember how many phones were on the walls. And just imagine the reaction from before Bakul was at the FDA, because there was no mobile medical guidance document, there was no mobile health group inside of FDA.
So how much later was it that some of that guidance actually was put into place? 2010, 2011?
It was 2010, 11 timeframe. And you really have to kudos to the FDA, but kudos specifically to Bakul Patel, who, as many of you know, recently is the newly anointed director of the CDRH's Digital Health Center of Excellence, right? And Bakul began this journey that said, look, we don't want to be perceived as an inhibitor of innovation. Rather, we want to help accelerate innovation, but we want to do it in a way that's clinically responsible, that relies on a quality management system, so patient safety, good manufacturing process. And in many ways, he's been a force. He's been an amazing force inside as well as outside, with organizations like the IMDRF, who have taken this model for innovation in a clinically responsible way and brought it forward. And so kudos to that. But yeah, I think it's been a journey and a learning for all of us, right?
Right. And so explain a little bit of the process that you had to. So you had to get FDA clearance, right? It was early on. The device, the use of these devices was not then what it is today. I mean, so talk a little bit about that, and then think about maybe in the early days, how did you think about adoption of your product, right? Your solution, because there was so much, greenfield to cover. I would have been really concerned as an innovator, as an entrepreneur. I would have thought, if you build it, they will come. But my God, the building is going to take a long time. How did you all think about it?
Yeah, so I think it's a series of steps, Paul, that first as if you put yourselves in the shoes of the healthcare ecosystem actor, one actor could be the payer or the insurer, another actor could be the hospital system, IDNs, right? One could be the actual healthcare provider themselves. When you look at these constituents, there were certain things that you couldn't take for granted. So for example, you wanted these things to have efficacy. You wanted them to have proof that they actually delivered the intended value proposition. And the gold standard for doing that is the randomized control study, just like you do for a new drug or a new medical device. And so it's Dr. Collins' famous quote from the NIH, right? Is the absence of evidence the evidence of absence, right? In English, if you want to be a player, you better have evidence that your thing works and it works with an intended use.
That's right.
And so your check mark number one is you better have evidence. The check mark number two is, yeah, it's got to be safe for people to use. And at the time, in absence of mobile medical guidance document and all of the evolution that's happened with the FDA in terms of SAMD, or software as a medical device, we were under the accessory rule. We were taking data from a predicate medical device, in this case, a class 2 medical device called the blood glucose meter. You're taking it, interpreting it, analyzing it, and providing real-time coaching that was precise to the patient's med regimen, that was precise to their comorbid conditions, that was precise to their medical history, et cetera. And then you're presenting longitudinal insights based on, hey, this is how you did with your glucose, this is how you did with your med adherence, but let me also tell you correlatively how you did, hey, this is your glucose excursion, and it was caused because of maybe this medication skip or because of this violating meal, et cetera. So to do that kind of stuff, you're put into class 2 world, you're sitting on that side because you're actually giving, higher risk guidance, right? And so at the time, that was the pathway that was chosen, right? And in order to do that, there's a certain level of rigor. You have to have a quality management system in place. You have to have evidence that you actually follow the processes that you say, that you measure and you continuously improve. Bakul calls it a culture of quality. Right? Can you ensure product quality, safety for the patient? Can you ensure that you actually measure and monitor and improve continuously? So these things now become what I would call foundational. Right? So I think that foundational piece hasn't disappeared. For people today who are entering this equation in 2020, those foundational things are absolutely important. Clinical trials, FDA clearance, cybersecurity, you're starting to connect systems and devices to EMRs, to wearables. There are certain principles, as you know, Welldoc was one of the companies who co-founded the Digital Therapeutics Alliance, and there are 10 tenets, principles, core principles. If you want to go to dtxalliance.org, you can see them listed out there. But I think the pathway of rigor, if I were to summarize it all, the pathway was one of rigor that would have been the same rigor had you brought a medical device or a drug to market. Why would you not apply the same rigor to bringing software to market if it's going to treat, mitigate, manage a disease, right?
Yeah, so go back on that one a little bit. Talk about the evidence, right? You said if you want to be taken seriously, you have to show up with evidence, right? So talk a little bit about the evidence, the process that you went through. How did you get that evidence into sort of the public domain? Were there skeptics out there, people accepting it? Just talk a little bit.
Yeah, absolutely. So going back to that notion of this gold standard being a randomized control study, you need a third-party principal investigator. You need somebody who's going to be, overseeing this in an objective way, and you need to design a study of sorts. And so we were very lucky to work with University of Maryland's Charlene Quinn, professor of epidemiology. And she had done a number of clinical studies and trials before, more in the pharmaceutical domain. And this was kind of the first, if you would, with software as a medical device. But we use the same principles. It says, look, you have a placebo group, standard of care, normal care, and you have an intervention group, that who's using your intervention, your solution. And you look for principal outcomes. In our case, it was hemoglobin A1C, and you powered a study for a statistically significant p-value delta between intervention and control. So you're effectively taking a page out of a well-established and well-known story of how to, if you would, implement that rigor. But now you're applying it in a domain that's software as a medical device. And I think that process, you complete the study analytics is completed. You then publish in a peer-reviewed medical journal. today we're fortunate. We actually have, if I'm not mistaken, more than 50. If I think the count may actually be 52 peer-reviewed publications that show efficacy, that show cost savings, et cetera. And I think this is important. It's an important, whether it's diabetes, whether it's musculoskeletal, whether it's neurological, whether it's respiratory, there's an opportunity to show that software as a medical device can actually deliver value that you can't achieve with just drugs alone or just with clinical care alone. So I think that rigor, going through that randomized control study process, doing these publications, is very important. And I think last point on this is every opportunity we get to work with payers, every opportunity we get to work with our clinic customers, where we can publish, we do. So one recent example, which I have to call to attention, this is fascinating, is New York City Health and Hospitals, the largest public hospital system in the U.S. It's predominantly serves Medicaid patients. It's a safety net hospital, as they call it. And Dr. Nicola Davis, who's the principal investigator, just published recently at the ADA in the summer a 1.1 drop in hemoglobin A1C versus a 0.1 drop, the 10x difference for people who didn't use a solution. And what was fascinating, this is inner city New York, it's the Medicaid population, 40% were Hispanic. They used the Spanish version of BlueStar. And so it's a real opportunity to continue. You know, if you think of Stephen Covey in his book, The 7 Habits of Highly Successful People, and he talks about sharpening the saw, there's an opportunity for digital health companies to continue to keep that element sharp, which is their outcomes and their effect, if you would, on clinical as well as economics.
So keep going on this a little bit. You said, you have to develop the evidence, you have to publish, you have to get it into the public domain. For entrepreneurs that are listening in, there's a balance, right? Because it's not inexpensive to run these studies. It's not inexpensive to get published. And so how did you guys approach it? And how'd you think about it?
Yeah, so the great news is that things have evolved. So there's two things that are point worthy. One is the notion of what FDA calls real world evidence. You can actually put a product into the market under an enforcement discretion categorization. And you can use that to actually gather data, understand, make the claims, then submit for a higher classification if you choose to. But use that data to actually understand, impact, assess, et cetera. And you can still use that as in a commercial sense, right? So you can actually use that enforcement discretion product to start driving revenue, using in that parallel real world evidence to then make the claims you want, submit to the FDA, exceed away to the races. And I think those provisions didn't exist in our early days. Those provisions exist today because of the evolution, if you would, of mobile medical guidance from the FDA. I think today I would encourage entrepreneurs to take that same rigorous approach, take advantage of the fact that they can submit real world evidence, take advantage of the fact that they can put lower risk products into the market to then help understand, gain data, to make the claims they want to, and then submit for the claims, and then elevate their class based on their core strategy and what they choose to do. And not everybody has to do it. There are plenty of digital health solutions out there that have been successful without that pathway, right? And so what you do depends on what you want to do and where you want to affect. I think that people recognize that if you really want to make a difference in health outcomes as well as economic outcomes, you may have to go the extra mile. You may have to do things that are FDA considers to be slightly higher risk, which then puts you in a different risk category, therefore the need for classification.
Yeah. So you did the rigor, you did the random control. I love that because it is the gold standard. You got the publications, you got the literature out. Then what? So from there, did you seek out, diabetic prevalence in a Medicare population is quite different than it is in the commercial population. So did you then pursue coverage with Medicare and then later Medicare Advantage? How did you think about that?
Yeah, it's a good question. So you're now in the 2015-ish timeframe, what's important to note here is that when we got our first 510K clearance from the FDA, it came with a little stipulation, which was it had to be RX only. Right? So there was a requirement for a prescription. Because it was so new, it should be under the auspices of a prescribing physician. And even today, whilst we have, as of late 2018, early 2019, whilst we have OTC clearances as well, from the FDA. So you have both dual clearance for RX and OTC. At the time, it was RX only. And because of that, your model was relegated to being, I'm going to make this like more of a pharmaceutical model. And that's right around the time when our current CEO, Kevin McCraith, came on board, and he came from years, 2 decades plus of being in the biotech and pharma space, most recently with Human Genome Sciences that was subsequently assumed by GlaxoSmithKline. And Kevin first put a program in place. We called it it was a pilot program that said we're going to do a move where we're going to knock on doctors' doors and we're going to do a sample. So instead of me leaving a bottle of pills or a packet or a vial of something in a doctor's office, I'm going to leave sample codes. So there was a sample program. And the idea here was, can we do multiple things? One, can we actually learn what's required on the part of the physician and the integration of solutions into physician practices? This is a huge learning opportunity. Second, can we actually garner the interest? And can we demonstrate that there's an uptake, that physicians will adopt this kind of thing because it helps them manage their patients, it helps them improve their workflow efficiency, and it ultimately gets to better outcomes. Now, as of 2019, as you're aware, Paul, there's also remote monitoring codes that allow them to potentially bill for these things. So there's an economic incentive, right? So he started this. He started this journey that said, okay, let's start with that model. But I think one of the things we learned for sure is that it's not a one-size-fits-all, right? That whilst you may have one model that works for one part of the market, right, you may have to be flexible in terms of how this may work for, say, a payer or an employer, where there's no prescribing doctor. Just why we went back to the FDA and sought the OTC clearance as well. So the journey is one of, you start somewhere, use that basis to learn, but appreciate that it may take many models and many channels and many customer types to actually create the success and reach the different sizes, the portions of the population that are addressable. As you said, there are ways now, for example, that the Digital Therapeutics Alliance as a group is addressing, that says, can we go to Congress and can we put forth the concept of a new category of reimbursement for DTX products that qualify under all the DTA rules? At the same time, there are, the 99, 453, 454, 457, 458 codes, for example, that again, if you fulfill the AMA requirements for those CPT codes, then you can use those codes. So all of that to say, flexibility, a journey, right? Yeah. Multiplicity in the approach, those are all important.
Yeah. So there's a question from the audience on the platform itself. And we haven't really talked about that. I want to come back to some of the things we have been talking about. You mentioned remote patient monitoring codes, and there's a massive opportunity there. But before we do that, the question was in agreement, by the way, with gold standard evidence requirements, that sort of thing. And then the question was around, is the solution solely device-based? So maybe you could just describe how the solution works. And while you're doing that, 2 other things. As you describe it, I think of the customer as the patient or the person, as opposed to CMS or the health plan or the employer. So I think of it as the end user, but I think there's a path to get there. So first, let's talk about the platform a little bit. Could you describe that?
Absolutely. So if you start at the top and you look at the 3 principal actors involved in this, and I'll use diabetes as the example, but clearly this is true for other chronic conditions as well. First, you have the patient themselves, no question, right? And this patient needs to do what? In the case of diabetes, and I'll use myself as an example, I have to manage my blood glucose, I have to manage my medications, I have to manage my food, I have to manage my activity, I have to manage my sleep, I have to manage my psychosocial symptoms, social determinants, all the 360 of what I call that governs my diabetes wellness, right? So there's a piece that—
Other than that, it's a layup, right?
yeah. There's a wee little thing called life that gets in the way. Exactly. Yeah. So now I have actor number 1, which is the patient. Actor number 2 is their provider, and not just their provider, it could be providers. So it could be their primary care, could be their certified educator, could be their endocrinologist, could be their cardiologist, nephrologist, etc. So think of the constellation of care that then supports, if you would, right, the patient. So that's actor number 2. And actor number 3 is the enterprise. And the enterprise could be a hospital system, could be the doctor, the office themselves, a clinic practice, could be an employer, could be an insurer, could be a state, a province, it could be a country, right? As you start to think about national healthcare. And our platform is designed to support all 3 actors. So if I were to use our most advanced product, BlueStar, that many of you are familiar with, which is our 510K cleared class 2 medical device, for the management of diabetes, type 1, type 2, most recently cleared BGM and CGM, okay? Interoperates with many EMRs, consumer devices, wearables, etc. Okay. The piece that faces the patient is the app, in simplest terms, that they download, right? And they use that to help make inputs either manually or through connected devices, Bluetooth connected devices, where they get real-time coaching on what to do that's precise to them. So for example, if you have a 255 mg per deciliter reading after lunch and I have the same 255, but you're on metformin and Januvia and I'm on Byetta and Lantus, then what you need to do and what I need to do to correct that may be different. So think about the precision of that feedback, right? Unique. It provides them the longitudinal, as I said, and it provides them the correlative insights, right? So it's that piece that faces off to them. The second part of the platform, to answer the question, is that which faces off to the doctor. Now, this is a fun one because if in our early days, and even now, we have a nice physician advisory board. No doctor wants to be bombarded with data that they don't know what to do with. Right? Can you imagine having 1,000 diabetes patients and getting it? That's not what they want. Rather, what they want is, can you send me a report? And can it basically tell me, hey, maybe this is where the patient was, say 3 months ago. This is where they are today. This is what's changed, and this is what evidence suggests, evidence-based medicine suggests I should do, but I'm the doctor, let me do what I think is right for my patient. Can you summarize that in a way that I can either receive via email, fax, can it also be integral into my EMR, okay? And what's fascinating is when doctors receive it's affectionately called the smart visit report. When they receive that smart visit report, they're 2 to 4 times more likely to make a medication change, as we evidenced in our clinical trials. And there was an incremental 0.7 delta in A1C achieved. No surprises, you're bringing the patient and the provider closer together. Doctor sees what's happening with the patient, titrates the medications, away to the races. They're at a better place, better therapeutic pathway. And then lastly, the third piece of the platform is that which faces the enterprise. So that's where you want to look at population health, and you want to look at engagement. You want to look at, frequency of use. You want to look at overall, are we improving all of the quality measures? So can I improve the number of people whose A1C is less than 9, like stars? Can I improve the people who have their LDL, cholesterol, and blood pressure under control? Eye exams, foot exams, flu vaccinations. Think about the full AADE 7 standards of care. Can I now show improvement at the population level? So platform is a sum of 3 things: that which faces the patient, that which faces the doctor, that which faces the enterprise. On the second question, on the difference between the customer and the end user. The end users are 2, the patient and the provider. The customer in our case is an enterprise. So we've chosen, our strategic intent is a B2B2C model. We will sell to the enterprise. They will make it available to their end users, patients and providers, if that makes sense.
Yeah, makes complete sense. Now, there's a few more questions that have come in, but I just want to poke on a few things there along the way. So you're really connecting the patient, the provider, and a care team. You call it an ecosystem, but you made reference to coaching. Talk a little bit about the coaches. Are they certified diabetes educators? What do they look like? Where are they in the process? How does that work?
Yeah, so I don't know, maybe wires got crossed. The software itself is doing the coaching. Because this is an AI-driven software that's actually doing the coaching. There's no humans involved, okay? Now, I would rather use, so if I go to a payer or an employer who has their own network of coaches, or they have their own network of educators, I would rather use this as a tool to empower them rather than bringing a parallel universe of my own coaches, right? And so We know one of the issues with human care, of course, is it's expensive and it's not scalable. And from a quality perspective, a machine will, an AI-driven machine will tend to do and deliver more consistent care than, say, humans. And that's one of the things we've learned, and that's one of the things the industry knows. If I were to see 5 diabetes educators, each one may tell me something different. Evidence is evidence is evidence. You got to do X based on all these conditions. So the coaching is done by the software, but the data is there, the alerts are there, etc., for coaches to act upon if you want to augment. So think of think, Paul, of a concentric circle model where you have the patient and the software and the provider in the middle of the circle. Then you can add a layer of coaches, you can add a layer of services, you can start to build this model. And why that is attractive is it's scalable. By definition, software is inherently scalable, and it does it at a margin that's better than that of human care. So that's where the coaching element is. It's all AI-driven software, if that makes sense.
So now let's go to a question from the audience, and this is where I think it's going to get real interesting. The question is, how are you different, or do you differentiate yourself from the likes of a Livongo and Omada? And of course, the world now knows that Teladoc and Livongo are getting together to probably broaden disease categories. So how do you all fit competitively?
Yes, people always ask us this question, and I always say, you know what, I can't speak for what they do, and I can't speak for their strategies. That's known to them. But I can tell you what we do, which is a maniacal focus on outcomes. And outcomes for us means both numerator health outcomes as well as denominator costs. So on that one alone, typically, when a patient uses our product, we see somewhere in a 1.5 to 2 point A1C reduction across all starting A1C bands. Now, one of the things we uncovered with a study we did with IBM Watson Health, then Truven Analytics, is that you have an ability to look at, say, a cohort of patients, and you have the ability to stratify where their A1Cs are, okay? So for example, 4 bands. I have a cohort of 1,000 patients, and they fit into a band of an A1C of 6 to 7, which is well controlled, okay? 7 to 8, 8 to 9, moderately elevated, above 9, the so-called train wrecks, okay? Truven tells us, by the way, that the distribution in the United States in those 4 bands are 30, 34, 16, 20. 30% of people are well controlled 6 to 7, 34% are 7 to 8, okay? 16% are 8 to 9, and the remaining 20% are above 9. And then you observe fractionally how much you drop each band. So can I get a 2 point A1C reduction out of a guy who starts at 7? No, it's not feasible. But you better get a 2 point reduction for somebody who starts above 9, otherwise your solution's not very good, right? What we've observed is that 60% of people who start above 9 have drops greater than 3. That's fascinating. By the way, the FDA considers a drop of 0.5 efficacious. That's what it's required to clear a new drug. So you're talking about 6-7x of what the FDA requires. I said this in San Francisco once, it was a tectonic shift in A1C. I'm like, wrong word to use in San Francisco, right? It is a tectonic shift in hemoglobin A1C. So that's one thing. Second, with IBM Watson Health, we were able to show that for people who start with an A1C above 8, right, on average, you're going to save about $3,100 in the US healthcare system per patient per year. Okay? And when you think about the total cost of that diabetes patient, which could be anywhere between 18 and 23,000 on average, you're talking about a big chunk of money, right? So
wait, I want to push on that just so I understand that a little bit. 3,100 per year if their A1C starts above 8, and then you're able to bring it in control and keep them in range of 6 to 7 as you described.
And I'll tell you, so let's go further on that one, which is a fun one to discuss. What is total cost, right? So IBM Watson Health said, this is how you should define total cost of care. It's the sum of 3 buckets. So bucket number 1 is acute costs. Bucket number 2 is supplies. Bucket number 3 is comorbid. So let's evaluate each one. Bucket number 1, acute cost, is the sum of 3 components itself. It's ER, it's hospitalizations, and it's doctor's office visits, okay? 3 things. Bucket number 2, supplies, is also the sum of a composite. It's meters, strips, CGM sensors, medications is a large one, compression stockings, whatever other DME that shows up in an ICD-10 or 9 code. Okay. The third, we said, well, how do you measure comorbid? They're like, that's easy. The usual suspect 5, right? Hypertension, hyperlipidemia, retinopathy, neuropathy, nephropathy. Okay, so that's total cost of care. And what we noticed is that if you take a patient and you look at their hemoglobin A1C readings throughout the year, typically 4 is when you're supposed to get it checked quarterly, right? But not everybody gets checked 4 times. So we said, can you find 2 readings in the same band in the same year and declare that person to be stably in that band? So for example, if I had a reading of 7.8 and 9.7, which band do I belong in? I don't know, right? It could be either one. I might have had a good day or a bad day. But if I have 2 readings that are 8.4 and 8.9, I can say mathematically that I'm stably within the same band, and I'm going to use me in that band cost calculation. So you're effectively taking people from a high A1C, high cost band, and you're shifting them to a lower A1C, low cost band. And because they have the market scan database, 220 million patients, annual adjudicated claims data, we could see what the costs per band were. So in English, if I have 4 bands, A, B, C, D, and I know the cost of each one, and I know the number of people that I'm starting with in each one, and then I count the number of people at the end, I can calculate what my estimated cost savings is going to be very easily. And then you can measure, as we've done recently with studies where people have shown a 55% reduction in ER visits, or they've shown a 30% reduction in ER utilization, right? So health outcomes, economic outcomes. Third point, what we do is a singular user experience that helps manage type 1, type 2, hypertension, weight, et cetera, within a singular user experience. And it's all done via software with this report that goes to the healthcare provider, right? That's really important. And then all of the structural things I told you, all the clinical trials being FDA class 2 cleared, not the device. I can have a blood glucose meter, as many of these companies that you mentioned do. That, of course, is a class 2 medical device, but is the software itself, is it software as a medical device? In our case, yes, it's a class 2 cleared medical device.
So can I ask on that a little bit? Are you device agnostic? I mean, so BGM agnostic?
So BGM agnostic, wearable agnostic, EMR agnostic, which actually, it's an interesting point you raised, Paul, because if you put on your implementation hat now, you're the enterprise, what are you going to do? You want to reduce points of friction. You want to reduce points of friction for the adoption of your technology. As soon as I say, well, it's got to be my meter, or it's got to be only this, you've just sliced out a lot of other things. So I think we can take something from the software and wireless industries, which other people have learned in other industries, that a device agnostic play inherently will have more scalability. As a patient myself, I have 5 blood glucose meters. I have one in my bag, I have one at home, one in my car, one in my office that I never use because I don't go to my office anymore, right? So like that, they're all different. You should never force me to, let me use what's convenient for me. If that's the one I have, let me use it, right? So
yeah, that's
we
right.
don't want to dictate that. It's reducing the friction of adoption, right?
Yeah. A couple more questions from the audience and then one comment. So let's go to a question first on patient cohorts, right? There's some patients that are harder to reach than others. There's different socioeconomic classes. People have better internet capabilities. Frankly, mine goes in and out when my kids are here playing games. And so how do you reach the patient populations based on where they are?
So that was a very compound question. So let's break that one into its fundamental pieces, because there was stuff that I want to discuss on each one. So connectivity, first thing you mentioned. This software as a medical device uniquely works online and offline. Every other digital health solution in the market today requires you to have a live connection to the internet via a Wi-Fi or cellular connection, or a phone call to a human being, okay? Doesn't work when you're in a tall building in New York City above the 27th floor because the look angle to the tower is gone. Doesn't work when you're in an underground parking garage. Doesn't work if you're flying on an airplane, et cetera, okay? Unless you have Wi-Fi. As one of the first to get cleared by the FDA, it was a stipulation, hey, it's got to work online, offline, especially for the out-of-bounds algorithms, for the things that are higher, alerts, hypoglycemia, hyperglycemia, et cetera. So online, offline. So connectivity is not an issue there. Second, Accessibility, okay? So this is where I think there's a little bit of a misnomer in the industry on two things. One, they're like, well, it's not going to be, how are people in Medicaid going to use it? And they can't afford it. Believe it or not, Medicaid, the use of the cell phone, smartphone, okay, oftentimes subsidized by state programs. That cell phone, that smartphone is their PC, their phone, their TV, their lifeline. So we found in Medicaid populations that cell phone is actually the most prevalent device. They use it for everything. So their engagement is high. And there are programs, and there, of course, courtesy of all the Android low-cost phones, there's abilities that you can actually provide, not just the device, but you can provide very low-cost connectivity. Courtesy of all of the MVNOs, the mobile virtual network operators, the Cricket Wirelesses, all of those guys that sit on top of the Verizon AT&Ts, right? Third is Medicare. There's always this, my dad won't use that, they're actually our highest engaged users, on average 38 to 44 times a week. And so we're seeing that. And by the way, the solution is not just available on smartphones, an app, it's also available on a PC browser. And what's amazing for Medicare today, that's still their preferred method of interacting with BlueStar. It's through the web access versus the mobile app. So accessibility, you're leveraging the power of the cellular platform and apps. Affordability, by definition, it's a lower cost because you're not paying for the human coaching in the call centers and things like that, right? And continuity. No, don't require a cellular network, don't require Wi-Fi networks, it'll work online, offline, etc. These are things that technology fundamentally enables. That's what allows you to have the higher numerator and the smaller denominator, therefore the fraction and value is higher, right?
Right. Yeah, makes sense. Let's tackle the go-to-market question now. You mentioned, I think of them as aggregators, so health plans, employers. You mentioned the end user. I think we all understand who the end user is. How did you approach the market, and what learnings did you have there? I mean, selling to health plans is hard as hell. Everybody knows it. Selling to employers is not easy because they get bombarded with different solutions and they can't figure out what the ROI is. How did you all think about your go-to-market?
I think it's an evolution, and I think it's a learning experience. And I said it earlier on, I'll say it again. It's not a one-size-fits-all. I think if you recognize that, we were on a panel a year ago where Stephen and I were together at Health, and Chris Hogue from Propeller Health was there. And Chris said something that stuck in my mind. I was like, oh, he's the straight guy. He's actually telling it truthfully to the audience, which is, we're on the third iteration of our first business model. You think about it, we're on the third iteration of our first business model, is what he said, right, to the audience about Propeller Health. And I think understanding that flexibility is really, really important. So one answer is you got to be flexible. That means you have to have, if you're lucky enough to have an RX and OTC, great. If you can have a licensing model that's per user, per month, risk, not risk, etc. Fit into what the payer wants to do with you. If they want to do a value-based agreement, do it. If they want to do it on a per member, do it, right? So you should be flexible to accommodate that. Second thing, going to market, you're well served by having strategic partnerships. You're well served by not trying to do the lift completely on your own and having channel partners, right? So you start to think about who has accessibility to the employer market, who has accessibility to the payer market, who has accessibility to the physician environment. And you start to think about, employment benefit consultants. You start to think about medical device partnerships. You start to think about other partnerships. I think partners are a very important, and a lot of the digital health partnerships, the digital therapeutics partnerships today, and you start to think about the obvious ones, are more in the early stage. How do I get a product through clinical trials, pharma partnerships, right? How do I get a product through FDA clearance, et cetera? There are commercialization partnerships that can be very valuable because, in effect, you leverage the breadth and reach of a partner, to take you into the channels you want to. So I think it's those two things really. It's the flexibility of your business model, and it's the partnerships that help you reach, if you would, is what I would think about.
So if you look at and fast forward to where you are today and where you see the future, you've mentioned partners, you've mentioned employers, you've mentioned health plans. What do you see the mix of your business changing over time? Do you see, it's going to come more through distribution partners? So that's the first. And then I've got a follow-on question to that about the technology-enabled solution versus the people part of it. So I'll come back to that one. But the first question, if you would.
So let's step out of the muck for a second, Paul, and let's put on our payer hats for a second. You're United.
I got a lot of those laying around. 32 years of it.
So I would assert, and I could be wrong, but I would assert that United and Aetna and Cigna and the Blues, yes, they look at each other as competitors, and they look at each other to conquest new markets, etc. But if I'm their chief strategy officers, is that what's keeping me up at night? No. I think what's keeping them up at night are the disruptors. It's the unusual suspects in this equation, which are who? People like Amazon, people like Walmart, people like Best Buy, people like Walgreens. Why? They have access to people, right? And they have, dare I say, frictionless, very easy to understand, it's not reams and reams and reams and reams of paper that you have to understand the relationship between you and your health insurer. It's a simple relationship, right? And so I think when you look at that part of the equation, the question then is, well, where do you see this going? And your question is, do you see it, do you see your mix changing? It goes back to my first point. I think that it's fluid. I think that these will absolutely be viable channels. And if you now add geography into that mix, in some countries, especially the emergent economies like India, China, Sub-Saharan Africa, etc., the predominant model for healthcare is you pay out of your pocket, right? It's a direct-to-consumer kind of thing. So the health insurance isn't as prevalent. Yes, it's being introduced and it's growing to a certain extent, largely because of multinational corporations and their existence there, right? All the think of Jack Welch and his legacy of IT and tech in India, right? But it's still a large kind of cash pay thing. And so where you have an opportunity, I think, right, to look at emergent models, could be partnered with retail, could be partnered with a supply chain aggregator like Amazon, right? And it could be absolutely with the payers. And so I think what you're going to see is you're going to see that it's an ebb and flow between different avenues, between different customer types and between different channel types and different business models. So I can draw three vectors in my hand, like we electrical engineers are taught to do this, the Fleming rule. I can't do it with the fourth dimension, but there's four dimensions this an equation that says it's the fluidity, and again, it's not one size fits all. I think certain companies will find success in certain permutations of those. Other companies will find success in other permutations. And I think we're at the infancy. I mean, let me just use diabetes. If I were to take all the digital health companies in diabetes today and add up their total subscriber volume, just for fun, it's probably near 1 million-ish. Okay, there's 27 million people in the country with diabetes, and there's an additional 400 million worldwide. Right? We're not even close to scratching the surface for anybody, right? And so I think that it's going to be fluid. I think people will succeed in different ways, and more power to them. I think at the end of the day, we're all after the same thing. We want to change and improve the lives of people. We want to drop healthcare costs. That should be the aspiration for all of us, right? We'll do it in necessarily different ways.
Yeah. There's another kind of question comment from the audience, and it's a really interesting one for me. And it's this, I don't know if it becomes this merging or integration or coming together of technology, so AI and platforms, and the people part of it. And the question or comment came in from a nurse who said that people kind of love what I do, and they love the experience and education that I create. And I can actually relate to that. The business that I'm in it's a heavy care provider kind of model, supported by technology, enabled by technology, of course. And she went on to say, I think it's a woman, went on to say that the profession feels a little bit under duress because it's this, you're a cost, and we gotta squeeze out some of the cost. So now I think about that, and I think about the enablement of technology. And then I think about your last few comments. You said there's 1 million subscribers or users in a country, US, that has 27 million people that are diabetics, and there's a lot that are hypertensive and are moving that way, 400 million worldwide. What advice do you have for the human component of the care, these sort of care models?
Oh, very easy. Please, 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 if I didn't say please, do not think that digital therapeutics supplant you. It's exactly the opposite. Rather, a digital therapeutic will let you stand on a platform so you can reach higher. Here's why. I have an educator today as a patient myself, diabetes educator, and that educator can only see X number of patients in a day. And by the way, with COVID-19, okay, they can't see anybody. Everybody's canceling their appointments, okay, right? Now, so forget about that. Just put that aside for a second. Let's say that you could actually see them. Well, people cancel. I'm late. The kids' soccer practice ran over. Can we reschedule it? All right. And then for the people that they do see, let's say they have 10 people and they get through a list of 4 or 5 and they're all green. They didn't need to be seen that day, but 6, 7, 8, 9, and 10 all had issues. 6 had hypoglycemia, 7 had mood issues, et cetera, et cetera. What this allows you to do, if you were to create a triangle, the base of the triangle is the widest. That's where technology plays its biggest role. It scales. Why don't you put everybody through that first base? It's a really cost-effective way, and then use that to then inform, oh, these people actually need to be siphoned into a diet specialization human program. Great, do it. These people need to have psychosocial counseling. Okay, great, do it. These people, they're fine. So when you actually are a payer, it's like a portfolio. You're optimizing your cost structure, one. You're optimizing your capacity to cost ratio. Now, all of a sudden, that fixed capacity of 10 diabetes educators, they don't just see 100 patients, they can see 1,000, right? And they can see a great deal of them virtually, and they may even be able to bill for it. So I would say, please, again, for the 8th time, don't think that this is a threat. It's exactly the opposite. Take advantage of it. It's an enablement for you to reach higher and reach further.
Yeah, I tend to agree with you. I often wonder and think to myself, I'm in the business of care delivery, not me personally, but our team, and we're aiming toward technology. And I think about the technology enablement companies like yours, are they going to go in the opposite direction and into the care provider, care delivery business? Question for another day. There's one more from the audience, and then I want to ask you sort of a question about your personal journey. The question is about medication regimen and the importance of that to the cohort of patients you're involved with. And the questioner goes on to say, especially around the high incidence of polypharmacy. And this is it, right? This is where the ROI gets earned, I guess, right?
Absolutely. So a little bit of underneath the hood that I can share with people, which is, as I mentioned earlier on, BlueStar helps manage your metabolic things that you can measure, like glucose, weight, blood pressure, etc. It helps manage your medications in a very, very detailed way. It helps manage your food in a detailed way, your activity, sleep, psychosocial, symptomology, social determinants, a full spectrum, okay? Now, a very large part of that is medications. And you start to think about not just orals, you start to think about complex orals like sulfonylureas that may induce hypoglycemia. You start to think about the non-insulin injectables, Trulicities, et cetera, GLP-1 class, SGLT class. You start to think about basal insulin, bolus insulin, and then you think about all the combinations therein. When a patient actually registers into our product, we assign them to a medication class. There's actually a number of medication classes, and the real-time feedback and coaching changes for each class based on that, right? So absolutely a critical pillar for us is med adherence, med regimen management, and it's all of the insulin management insulin to carb ratio, sliding scale, correction factor, titration, etc.,
Right.
that are all automated, right? And so it is a very, very significant part, I think, which is also why we're a class 2 medical device, because you're doing that kind of stuff. It is a very significant part. I mean, as a patient myself, my doctor is a smart guy. And if he puts me on a drug regimen that he thinks is going to help me, provided I do all the other things like not eat the extra slice of pizza every day for lunch and exercise where I'm supposed to exercise, my outcomes are probably going to be good, right? If I follow that medication regimen, right? So I think in many ways, meds, it's critical for us. It's critical for the success of the platform. And I think part of what we do, we make it frictionless. We connect to all the pharmacies, for example. You can upload your meds very easily, or you can manually enter them because we're connected to a database on the back end. Again, removing friction, making these vectors of engagement easy to act on and meaningful for a person, for them. It's useless for me to give insulin education for a person who's on metformin. It's irrelevant. So
Right.
AI-driven personalization. So you asked, how we're different. Outcomes numerator, outcomes denominator, AI-driven personalization, device agnostic. Those are the types of things that resonate with.
So we're right at the top of the hour. You've got 30 seconds because I know you have a call to go to. Words of advice for the audience.
Flexibility, adaptability, and dare I say the one that's most important to me, which is you have to believe in your mission, and you have to have a passion for believing in your mission. This is about changing people's lives. And it's not fun and games because a lot of people suffer in very bad ways from these diseases, whether it's diabetes or respiratory or neurological depression, etc. And we have a shot at helping them in ways that are friendly, in ways that fit into their lives, in ways that create changes that they can't do with traditional care alone. And it's almost as though we have a responsibility and a duty, dare I say, to do that. And so be passionate about delivering that value proposition and be passionate about putting yourselves in the shoes of your ultimate end users, which are the patients and the providers, to help them solve these healthcare conundrums for the future.
You've been awesome with your time. Very grateful for that. Appreciate all your insights and your product and your solution, and enjoy the rest of your day, Anand. And for everybody out there, thanks for patiently joining us today. Take care.
Thanks, everyone. Bye.
Now.